Good afternoon, everyone. We will begin shortly. We are just waiting for everyone to just roll in.
Abby in. Um, Says she's in the waiting room.
We invited everyone from the waiting room. Let's see. And Kim, do you want someone to be sharing the PowerPoint slides, or are you fine sharing the slides and talking through?
Abby's still not able to get in, but she's going to be sharing them. So hopefully we can get that. Should she try again?
E-
Maybe she should leave and try again because she's not able to get in. I just told her to try again because she's going to be sharing the slides. So we need to wait for her and then we can share them if you want us to go ahead and do that.
Yeah, I don't see her in yet.
She said she was going to try to get out and try to come back in because she's not sure why she was still in the waiting room.
Maybe in the meantime, if folks could put in the chat your name, agency, which area of child welfare you're working in, and that would be greatly appreciated.
I think she's in now. I just saw her name pop up.
Yeah, I just let her in.
All right, so let's get started. Good afternoon, everyone. My name is Peter Guan, and I'm a program manager at CFPIC. Thank you all for joining our Calvin Brown Bag. Our Calvin Brown Bags are an ongoing series. Special thanks to CWDA for their support. This webinar is recorded and will be posted on our CBSI webpage. The webpage link is in the chat. I'm going to do that right now. All right. Today's topic is on continuity of care. The training session will be facilitated by Kimberly Lewis and Abigail Corsol. They will help you understand the situations when continuity of care is available to Medi-Cal beneficiaries and what protections continuity of care provides. Kimberly is the managing director and Abigail is a senior attorney at the National Health Law Program's Los Angeles offices. With that, I'll pass it on to the presenters.
Thank you,
Thanks.
Peter.
Great to be with you all. Abby is here now in the out of the waiting room. Abby, do you want to share your slides? Is that something you can do? So we'll be doing a presentation. We're glad to be here. Hopefully you have time for questions and conversation at the end.
Yes, okay, you should see my screen now, and let me start the slideshow. All right, are you all seeing the slides?
You see your next slide too, though. So as we need maybe the display speaker um, full screen maybe.
Okay. Um, okay, hold on. Let me try this again. And nope, you can still see both.
Yeah, maybe try from the beginning and do that. That might be I'm not
Okay.
sure if you try the other link from the
Yeah.
beginning slide, that one from the beginning link.
Yep. 1 second. Mm,
There we go.
is that better? Okay.
Yep.
Great. Okay. So Peter already gave you this roadmap. We're going to talk a little bit about what is continuity of care and then talk about how continuity of care operates in various situations you may come across. Mandatory managed care plan changes, mandatory moves from Medi-Cal fee-for-service to managed care, mandatory moves from Covered California to Medi-Cal, um, and then special continuity of care protection for people who are receiving specialty mental health services, and special protections for people who are enrolled in Knox-Keene licensed plans. So our goals for the training is that you'll be able to identify cases where a Medi-Cal beneficiary is and is not eligible for these continuity of care protections, and also that you'll know where to get some more information to determine whether someone's eligible, if so, what provider or service is entitled to that protection, for how long, and what, if anything, does the person need to do to take advantage of those continuity of care protections. So let's start by just the broad overview. What can be confusing is that we use this phrase continuity of care to apply to some different situations and types of protections, but they all go under the same name. So we're going to try to break that down a little bit. For the most part, when we're talking about continuity of care, we're looking at a managed care context. There's really no continuity of care for people in fee-for-service Medi-Cal, with the very limited exception of some specific protections that happened for people receiving certain types of prescription drugs when the Medi-Cal Rx program went into effect in 2022. So there were some of those protections for a very limited number of drugs that provided what is called continuity of care access in that context to allow people to keep receiving those drugs that are not otherwise covered in Medi-Cal Rx for up to 5 years. So since that went into effect in 2022, we're about 3 years in, so those protections will be in place for another couple of years. But otherwise, if you have somebody who is moving within fee-for-service or moving from managed care to fee-for-service, there is no continuity of care for people who are going in or remaining in fee-for-service Medi-Cal. The other thing I really want to emphasize is that continuity of care is generally available in situations where somebody is required to make a change to ensure continued access to providers. So the goal is to ensure people who are required to make a change have continued access to providers who are out of network with their plan, or have continued access to services that would not be authorized in the same way by the plan. But for the most part, continuity of care is not available when somebody makes a voluntary change, and we'll talk about that more coming up, but I know that that was implicated in some of the questions we got before the webinar. So just know that these protections are really in place to protect people when they have to make a change, they have no choice. But if somebody has a choice or there's a voluntary change, the protections do not apply. So as I said, continuity of care is mostly used when we talk about ensuring that somebody has continued access to a particular provider, even if that provider is not in their managed care plan's network. I would say the vast majority of times this come up is when somebody is newly enrolling in a managed care plan, and they have an existing provider who is not a part of their managed care plan's network, and they want to continue to see that provider. But it sometimes also comes up when somebody is in a plan and a provider leaves that plan's network and they want to be able to continue to see that provider. Note that it usually only ensures access to that particular provider for care that is already underway. So it's not, that the person can continue to see that provider on an out-of-network basis for any service under the sun that that provider provides, but really only for care that the person has already been receiving from that particular provider. Again, as I mentioned before, it also may refer to situations where continued access to a provider, a particular service, is needed without any gap, even if the person has to change providers. And often this comes up in contexts where you may feel less of a connection to the particular provider, but it's really important to maintain that service. So things like durable medical equipment, laboratory services. It's really about ensuring that you have maintained access, medical supplies to those services and supplies, even if you may have to get them from a different provider, but you want to make sure there's no gap in coverage of those services. And then another situation is where continuity of care ensures that someone has continued access to a particular facility, especially a residential facility. So again, there you may be getting care at a facility, and there may be multiple providers involved in the care, but it's less about ensuring that the person has access to those particular providers and more about ensuring that they do not have to change to a different facility, especially in a situation where someone is living at the facility, like a skilled nursing facility or an intermediate care facility, ensuring that someone will be able to remain in those facilities without having to move is another kind of continuity of care. So when does somebody have a right to continuity of care? We'll go into each of these in more detail, but these are sort of the main areas where it comes up. One is where somebody has to switch from one managed care plan to another in the same county. And this was the big issue last year in 2024, where we had new plans in a lot of counties. And so a lot of people were required to make those changes. It also comes up when somebody must move from fee-for-service to Medi-Cal managed care within a county. So either somebody who's newly enrolling or who changes from one eligibility category to another, and they're no longer eligible for fee-for-service and must enroll in a managed care plan. It also comes up when somebody must change from Covered California to Medi-Cal. Usually that would be as a result of change in household income. As I mentioned before, when somebody's provider leaves their managed care plans network. And then finally, it can come up when somebody's mental health condition changes such that they are moving from one system to another, either from managed care to the county mental health plans or vice versa, and their provider can continue providing the mental health services they need. In all of these cases, the provider must qualify, and we'll talk a little bit more about what that means in a few minutes, and the provider also must agree to continuity of care. So one of the big barriers to continuity of care can be the provider just doesn't agree. The provider maybe has left the plan, doesn't want to have anything to do with the plan anymore, even though somebody would like to continue receiving care from that provider. So some situations where somebody does not have the right to continuity of care. And again, this is where you'll really see that difference between mandatory and voluntary. So when somebody chooses to switch from one managed care plan to another within the same county, if you're in a two-plan county or a GMC county and you decide to change plans, no continuity of care in that situation. Or when someone chooses to move from Medi-Cal fee-for-service to a managed care plan. So situations where somebody is in a voluntary eligibility category and has a choice to be in fee-for-service or managed care. If someone exercises that choice, it does not entitle the person to continuity of care. If somebody's provider participates in the network of one of their other plan options. So again, if you're in a county where there's multiple plans and your provider is not in network with the plan that you chose to enroll in, but if you could have enrolled in a different plan where that provider would have been in network, you don't have the option for continuity of care. When you move to a different county, and I know a lot of you work with foster youth, and this is a situation that comes up frequently with children in the child welfare system. And I know Kim will talk about that more in a little bit, but just to keep in mind that when somebody moves to a different county, there's no automatic right to continuity of care. And then finally, these are kind of the obvious ones, but when somebody's provider dies, leaves the area, stops providing the service that the person needs, is disqualified from participating in the plan due to, perhaps a quality of care concern, stops participating in Medi-Cal at all, or is just unwilling to continue treating the person. In any of those situations, there's no continuity of care. So let's talk about some of these specific situations. Mandatory managed care changes within the county. So this, as I said, is what we saw a lot of last year when we had a lot of plans changing in different counties. In that situation, the HCS allowed for continuity of care for providers, and there Most provider types you can think of are eligible for continuity of care, but some are not. So at the end, we have a resource that gives you the full list of the providers who are eligible for this type of continuity of care. In this situation, provided for 12 months of continuity of care from the date that someone was enrolled in the plan. So if someone enrolled in January 2024, they were eligible for that 12 months through January 2025. Continuity of care is only available when a provider has a pre-existing relationship with the person, which is defined as having seen the person at least once in the preceding 12 months, is providing Medi-Cal covered services, agrees to accept either the plan's rate for those services or the applicable fee-for-service rate, is a state plan approved provider, so a provider type that is allowed for under our Medi-Cal state plan, and is qualified. And again, that qualification there's some discretion of the plan to determine what that plan will accept as a qualified provider. But really what they're looking at is, the provider is licensed for the particular service, and their licensure is up to date. They've completed any applicable training requirements, and there haven't been quality of care complaints made against that provider. For this type of continuity of care, this is one that has to be initiated by the beneficiary or their authorized representative or provider. So somebody has to affirmatively request continuity of care in this situation, and then the plan will approve it. And I know we got a question about how difficult this can be to request continuity of care and the challenges that folks are experiencing with that. Unfortunately, it is a bit of a plan-by-plan process, so I can't give you a one-size-fits-all about how to make the request. Each plan has its own way that you have to request. So the best I can sort of tell you at a high level is you're going to have to reach out to the plan, let the plan know, I want to request continuity of care, and then get information from the plan about what exactly the plan is going to require to ensure that continuity of care can be provided in this situation. Related to the plan changes in 2024, there was also, DHCS also provided what they called enhanced continuity of care. And this was really aimed at beneficiaries in special populations. Again, I'm not going to list all of them. We have a resource that, if has not already been provided to you, we can provide it that gives that list. The idea was that for those populations, continuity of care should happen automatically. So unlike what I was just talking about, where the beneficiary or authorized representative or provider has to make that affirmative request, for these populations, the plan was required to initiate continuity of care requests on behalf of the beneficiary automatically, and also to do some additional monitoring to make sure people were getting continuity of care and getting the services from those providers for the first 6 months of enrollment. Otherwise, same requirements for providers, have to have that pre-existing relationship, providing covered services, agree to the rate, state plan approved, and qualified. So the main difference for these special populations is that the plan is the one initiating continuity of care. Now, as I said, this was 12 months from 2024. So for the most part, unless people enrolled pretty late in the year in 2024 for some reason, those 12 months will already have expired. But if you all are seeing issues with either continuity of care or enhanced continuity of care related to those transitions, be interested to know what you're seeing and see if we can answer any questions. Another type of continuity of care for these situations where someone was required to change plans is continuity of care for certain authorized services, including durable medical equipment and medical supplies. So there, the requirement is that the plan must honor any active prior authorizations or courses of treatment for 6 months following the transition date, or until a reassessment of medical necessity has occurred for those ongoing services. And that was supposed to be initiated automatically for everyone, not just special populations, but anyone who was receiving those services. The plan was supposed to look back at authorizations that were on file and make sure that continued authorization was made available. There was also a requirement, a special sort of continuity of care provision around those 2024 plan changes about new specialist appointments. And this was really in recognition of the fact that often people have to wait a long time to see a new specialist. Somebody who had been waiting to see a specialist and had an appointment, in January or February, a few months after the transition, the goal was not to have them go to the back of the line and start waiting for that appointment all over again. So DHCS required plans to make a good faith effort to either schedule a comparable appointment, if that new specialist was someone who was not in network with their plan, on or before the appointment date, or allow the beneficiary to keep the appointment with the new specialist, even though this would be a provider that the beneficiary does not have that pre-existing relationship with. So it's sort of a special provision around these new appointments for that particular change in 2024. So as I said, these changes were really around those changes to the plans in counties in 2024. For the most part, now there won't be situations coming up where anyone would be changing plans within their county. Of course, in the future, we may see plans leaving or changing again, so we may see some of these continuity of care provisions coming back, but for the most part, these will be done at this point. The type of continuity of care that is ongoing and that you're likely to see is when somebody must move from fee-for-service to managed care. And this is going to look very familiar to you. It's really just like the continuity of care for people who are required to change plans. This is continuity of care specifically for providers who participate in fee-for-service but are not in network with any of the managed care plans in that county. And in this situation, people are entitled to up to 12 months of continuity of care from their enrollment in the managed care plan when their provider has a pre-existing relationship, is providing covered services, agrees to the rate, is state plan approved, and is qualified. This is another situation where the beneficiary has to initiate the continuity of care request, either the beneficiary, authorized rep, or provider, with one big exception, which is when someone is moving from fee-for-service to managed care, because their medical exemption request has been denied, that is supposed to be treated by their plan as an automatic request for continuity of care. So a little bit more about these medical exemption requests. You may be familiar with them. These are requests that people can make who are in fee-for-service Medi-Cal, who are required to enroll in a managed care plan in either a two-plan or geographic managed care county, who have a complex condition, which includes the third trimester of pregnancy, and it allows people to remain in fee-for-service for up to 12 months. It allows people to remain in fee-for-service for a period of time, but if that medical exemption request is denied, or if someone has been receiving a medical exemption, but it expires and is not renewed, that should automatically convert to a request for continuity of care, to allow the person to continue care with the particular fee-for-service providers who don't participate in any of their plan options. A few other situations that are coming up over the last few years with people moving from fee-for-service to managed care. As you all probably know, we've moved many populations who are receiving facility-based long-term care from fee-for-service into managed care. And so around each of those transitions, there have also been particular continuity of care provisions put in place to ensure people can remain in their current facilities without having to move, at least immediately. So we had the skilled nursing facility transition in June of 2023, the intermediate care facility transition in January of 2024, as well as the subacute care facility transition in January 2024. For each of those, people who were residing in those facilities at the time of the transition were entitled to up to 24 months or 2 years of continuity of care. So those will all be still in fact right now, although the skilled nursing facility one will be ending soon for people who transitioned right in June 2023. And those people were entitled to continuity of care when the beneficiary was residing in the facility on the date of the transition. The facility is a state plan approved facility, and the facility was qualified. So for this situation, it was kind of a combo deal. The first 12 months of continuity of care was supposed to happen automatically without the beneficiary needing to do anything. And then if the beneficiary wanted to extend continuity of care for that additional 12 months, for the full 24 months, the beneficiary had to make that request sort of toward the end of the first year to request another year of continuity of care. Similarly, when people are moving from fee-for-service to managed care, again, you have some protections for authorized services, including durable medical equipment, medical supplies, and non-emergency and non-medical transportation. So when people are moving into managed care from fee-for-service, their plan must allow them to keep any existing durable medical equipment and supplies for at least 90 days following plan enrollment. And the plan must also allow beneficiaries to keep their modality of transportation under any previous prior authorization, but they may have to change to a new transportation provider. So somebody who is receiving non-medical transportation in fee-for-service should continue to get non-medical transportation in their managed care plan, but they may have to use one of the plan's network transportation providers instead of whatever provider they were used to getting their services from in fee-for-service. And then similar to what we saw for the managed care to managed care transitions, for new specialist appointments, plans should make a good faith effort to schedule comparable appointment or allow the beneficiary to keep their appointment with the out-of-network provider. As I mentioned before, we also have some special protections for people moving from covered California to Medi-Cal. Similar to what we've seen before, for providers, there's 12 months of continuity of care for providers with a pre-existing relationship, providing covered services, who agree to the rate, state plan approved and qualified. And this is a type of continuity of care where the beneficiary, representative, or provider has to initiate that request. For people moving from covered California, for any authorized service or active treatment plans, the person is entitled to up to 90 days of continuity of care. And the plan is supposed to initiate that by contacting the beneficiary within 15 days of enrollment. This is a little broader than the services and active treatment plans that you saw for the other Medi-Cal to Medi-Cal transitions. It's really any service that is ongoing and authorized that someone has in place when they're coming into Medi-Cal from covered California. And then finally, well, not finally, the second to last bucket is people who are receiving specialty mental health services. And actually, it's people who are either currently receiving or who need specialty mental health services. There's provisions for continuity of care for providers of overlapping mental health services. So this is either somebody who is receiving specialty mental health services and their condition has changed such that they no longer need the specialty mental health services, as well as somebody who is moving from non-specialty mental health services to needing specialty mental health services. Now, as many of you know, there are many specialty mental health services that are unique, and providers have to have particular training or expertise to provide those services, and they're not likely to be the same providers who are participating in managed care plans or offering sort of the non-specialty mental health level of services. So it's really only sort of a unique subset of services where there's some overlap between the types of providers who can provide services, both on the managed care side as well as the mental health plan side. So perhaps things like psychiatry services for people who need medication management, certain types of psychotherapy. For those overlapping mental health services, people are entitled to 12 months of continuity of care when they were already receiving the services from that provider, and that provider is capable of providing the services they need going forward. And this is, again, one where the beneficiary, authorized representative, or provider has to initiate that request for continuity of care. This is really the last bucket, I promise, which is continuity of care under the Knox-Keene Act. So as you may know, Most, but not all, Medi-Cal managed care plans are licensed by the Department of Managed Healthcare in California under the Knox-Keene Act. County organized health system plans, COEs, are not required to be licensed under the Knox-Keene Act. Health Plan of San Mateo is licensed, and all of the other COEs plans are not. So for those plans that are licensed, they also have to provide the continuity of care protections that are provided for under the Knox-Keene Act. They're sort of worded differently in that statute, but you'll see there's actually quite a bit of overlap with the types of continuity of care we've discussed before. The main difference here is that the Knox-Keene Act also extends to situations where somebody's provider leaves their plan. So someone who's enrolled in a plan has been seeing a provider, and that provider decides not to contract with the plan anymore. The Knox-Keene Act provides some special protections to allow people to continue seeing their provider in that situation. So the first one is pregnancy. People are entitled to get care from an out-of-network provider for any care related to the pregnancy, both during pregnancy as well as the postpartum period, which is defined as up to 12 months after birth or the end of the pregnancy. In addition, people who have written documentation of being diagnosed with a maternal mental health condition may receive continuity of care for 12 months from that diagnosis or the end of the pregnancy, whichever is later. So somebody who maybe has a postpartum mental health condition that arises a couple months postpartum could potentially be entitled to continuity of care a little bit longer. Another situation is care of a baby or toddler. So care for an out-of-network provider for a child who is newborn up to 36 months, 3 years old. If that provider leaves the plan, they're entitled to 12 months of continuity of care. Scheduled or recommended procedure. This is sort of similar to that new specialist continuity of care type that we discussed earlier, where somebody has a procedure that has already been scheduled or recommended within 180 days of the date that the provider leaves the plan or the person enrolls in the plan that does not contract with that provider. They are entitled to receive that care that has either been scheduled or recommended. The Knox-Keene Act also provides for continuity of care for people with a terminal illness for the duration of that illness. So this one is a little bit different. You'll see most other types of continuity of care are limited to 12 months, but for someone with a terminal illness, there's no hard and fast time limit. It's just the duration of that illness. By definition, terminal illness is usually someone that's expected to pass away within 12 months, but of course, things don't always go the way they're expected. So if someone has a terminal illness, but needs to continue receiving that care for the terminal illness for 14 months or 2 years, they're entitled to continue seeing their out-of-network provider. For an acute condition, someone is entitled to receive care again for the duration of the acute condition. I'm hard pressed to think of a situation where an acute condition would last more than 12 months, but I suppose it's theoretically possible. So again, this one is not time limited, but it's really about getting the care to treat that particular condition. And then finally, serious chronic condition. This is the one that is 12-month limited, similar to what we see on the Medi-Cal side. So people are entitled to get care for their serious chronic condition for up to 12 months. And with a little exception here, the time necessary to safely transition to an in-network provider. So if they're not quite ready to make that transition at the 12-month mark, they might be able to get another month or two of care with that out-of-network provider to make sure that that transition can happen smoothly and safely. I know we got some questions specifically about enhanced care management and community supports and the continuity of care for those services. So we'll talk about those in a little bit more detail. So for that 2024 managed care plan transition that we talked about earlier, people who were receiving enhanced care management and community supports were considered one of the special populations who were entitled to the enhanced continuity of care. What that meant is that someone who was receiving either enhanced care management or community supports, if that person was required to transition to a different plan, their new plan should have taken affirmative steps to allow the person to continue receiving either the enhanced care management or the community supports from their existing provider for up to 12 months, if possible. The one sort of big gap here is, as you all know, community supports, each plan makes choices about which community supports they offer, and not all plans offer the same community supports. So if you were transitioning from a plan that had a particular community support and moved to a new plan that no longer offered that community support, there was no continuity of care requirement for that plan that does not offer that particular community support. Again, because of the enhanced provisions, the new plan was required to monitor the provision of either the enhanced care management or community support for the first 6 months after the transition to make sure that the person had transitioned appropriately and was actually getting the service. Okay, you've heard me talk a lot, so I'm going to stop now and let Kim tell you a little bit more about some considerations for foster youth.
Thanks, Abby. I know a lot of you do work specifically in the space of eligibility and or services for child welfare population. So wanted to touch upon that because I think the complexity of what you've already heard from Abby, which is quite a few different types of continuity of care and situations where it applies and populations where it applies, services to which it applies. And it can be a very complex web of kind of policies that have developed over time as a result of the changing kind of Medi-Cal delivery system landscape, moving people from one delivery system to another specifically. So very little, as Abby said, in the way of fee-for-service continuity of care. And I think even when you're talking about managed care, the complexity is greater with foster youth. And Abby just went through all of the various types of continuity of care and specifically the populations, which were just, we talked about the special populations who got enhanced continuity of care. Foster youth were a part of that transition and were in that protected group to get that enhanced continuity of care. So DHCS had a number of guidance letters that covered that specifically and the obligations related to foster youth moving. So for example, in 2024, there was a number of Coes County models, the county operated health system models that were expanded into new counties like Butte, Colusa, Glenn, Mariposa, Nevada, Placer, Plumas, San Benito, Sierra, Sutter, and Tahoma, and Yuba. So all of these counties moved into, in 2024, a single plan county, which meant that a number of youth in foster care, specifically around 5,000 and collectively in those counties, went into a mandatory managed care structure. So they moved from where they might have been in fee-for-service into mandatory managed care. And so they were, again, getting those enhanced protections. And then again, in 2025, Alameda, Contra Costa, and Imperial, specifically those single plan, what do you call it? They're very similar to Coes, but they call them single plan counties. Again, only one plan in the county. Foster youth and former foster youth were moved into mandatory managed care in those specific counties in 2025. And so those transitions included current foster youth, former foster youth, adoption, and anyone with an open child welfare case. So really this was a movement of multiple populations of foster youth into mandatory managed care, which I think is what some people have seen more recently in the last couple of years as continuity of care related to this specific population. Because as we know, the counties differ. Some which are mandatory managed care, single plan counties, foster youth don't have a choice. They're in that single plan or that Coes plan. They don't have a choice of fee for service. It's really the two models in California, which are the geographic managed care, Sacramento, San Diego, and then the two plan counties, including Los Angeles and a number of other larger counties, where there's a choice of plans, and therefore foster youth can also elect voluntarily to go into managed care. And that's where, although we're not talking specifically about that today, the conversation, it gets more complicated around making those decisions and making those choices. One thing I would just note is that there's a statute which is cited here on the slide which says that plans must pay for out-of-network providers when a county is moved to an out-of-county placement. So when you're change of county, I think was alluded to by Abby when we talked about beneficiaries moving from one county to another. I think there's not clear guidance on this question with respect to foster youth, because we don't think of foster youth as beneficiaries moving from county to county, but more placement by the child welfare agency into other counties. So there really hasn't been I think, clear distinction by the state on how beneficiaries moving versus beneficiaries being placed, whether by choice or not, is the same thing. I think this is where I think the complexity is greater, because there is less clear guidance on exactly what should be expected and whether that's considered a quote voluntary move by a beneficiary. Nevertheless, the statute does provide that an expectation that if you're in a plan and you move to an out-of-county location, that the plan you were in, if you were in a managed care plan, should retain obligations to pay for those out-of-plan services. Which, and if you read that as you would expect, you think that there should be clear obligation to keep them in that plan when they move out of county. But there isn't such clear guidance, and so I think what we know is happening is that a lot of youth who are placed out of county may be in a plan, and then they'll lose access to that plan either by policy of the receiving county or the county that sends them, or because there's some kind of auto glitch in the med system, which we've also heard about that counties experience, where as soon as you change the place, the address of the foster youth, that automatically disenrolls them from their plan, in which case they don't have any continuity of care or any access to their plan services. So this is I think an area where we expect and need more guidance and more kind of policy decisions by both really DHCS, but also it's something our office is trying to do more with, is to address the gaps in the policies and or lack of clarity that is causing a lot of inconsistency and different experiences around the state, particularly for foster youth who are moving out of county. The other piece that Abby alluded to on especially mental health services has its own set of rules that are not applicable to managed care plans, which is the presumptive transfer law that was enacted in California. And there's a whole bunch of different letters on that. They call them MHSUDS letters. MHSUDS was the prior name for BHIN, which is a behavioral information notice. So really they're the same thing, but just the previous name. So a lot of these particular guidance letters are kind of more details on how presumptive transfer happens when a foster youth is placed out of county, and whether that obligation of the plan that was in the sending county continues versus the receiving county, where they are supposed to take that responsibility over. So the specialty mental health plan or the behavioral plan in the new county where their place is now responsible for those services, especially mental health services. So that again adds complexity on that question of continuity of care. And then intra-county placements, just as not something we're specifically talking about today, but I want to also flag that we've seen lots of issues and concerns with intra-county placement changes where kids are moving continuously within the same county, and particularly in Los Angeles, which is so large, where the delegated networks of a plan may cause a youth to not have access to their providers any longer. So, we know that there are plans, and then there's sub-delegated plans where they contract with other plans, or there's medical groups where they actually subcontract with, and those have their own miniature network, which is limited. And so we see this sort of multi-level managed care structure having a great impact in terms of access for particularly foster youth who are moving quite a bit. And so that delegation network may be very limited, in which case there's a problem to get access to those providers and those services once they move. And then providers also obviously moving, it may not be anywhere near where the child is moved, even within the same county like LA, where it could be hours away. All right, let's go to the next slide. So I think what we know is that fee-for-service versus managed care is a larger question we need to be thinking about, and we need to be working on in terms of how that decision, whether if they have a decision, how that decision is being carried out, and how that's impacting continuity of care for foster youth. to add to, I think, the specific complexity of this population as well is the multitude of existing navigation access points for foster youth. Abby talked about ECM, right? But we also have a new obligation as of 2024, which is the child welfare liaison, which means every plan is required to provide such a liaison to foster youth in their plan. So they should know who those members are, and that that staff person is responsible for the members' coordination of care, including coordinating with their ECM lead case manager, if they have one, because foster youth are a population of focus that should be getting ECM. And so obviously it's not mandatory, but that ECM has its own robust care management model and set of obligations. So you've got the child welfare liaison, you've got the ECM lead care manager involved. All of those sort of touch points are within the plan should be coordinating to ensure that these foster youth are getting what they need and that they're getting ongoing access to care. To add complexity further, there's also the healthcare program for children in foster care that is the public health nurse program located within the county child welfare agencies and some probation departments that provide public health nurse expertise in meeting medical, dental, mental health needs for youth in foster care. And so you have those folks also involved in those cases. And so they're making some potential decisions or providing advice to child welfare workers about what that needs are medically and in relationship to the delivery system potentially that they're in. And then there's the Ombudsman Office, which has really mostly been involved in managed care emergency disenrollments for kids in foster care when all of the problems arise when kids are placed or moved and they can't get access to care at all. So that's when sometimes they get asked to be emergency disenrolled or enrolled into in or out of a plan. And then finally, there's the community health workers, enhanced community health workers benefit, which is also fairly new to managed care, but also now to the enhanced care community health worker benefit is a very new benefit that's yet to be implemented in specialty mental health. And the whole role of community health workers is education and navigation. And so yet again, another person responsible that could be involved in working with a foster youth or a child welfare agency to ensure access. So we've got in some ways too many touch points in which the navigation and the sort of air traffic controlling is perhaps not as clear as it might need to be in terms of who's responsible for what and who is actually making decisions. So that's the sort of landscape of the complexity here I wanted to kind of leave people with. And I pass it back to you, Abby, on the case examples.
Yeah, thanks, Kim. I know we have just about 10 minutes left, so I don't know if there's any questions that have come in that we should address. Otherwise, we can go through our examples.
No, Abby, I haven't seen any questions come in so far.
Okay, great. So let's go through some examples just to get a sense of how this all comes together in practice. Our first example is Selena, who enrolled in Medi-Cal in Imperial County in November 2024 after losing her job and her employer-sponsored insurance. She receives regular dialysis. She was initially enrolled in fee-for-service Medi-Cal starting in November, and began receiving dialysis from RISA Dialysis Center. Then on January 1st, 2025, she was enrolled in Community Health Plan of Imperial Valley, which does not contact with RISA, her dialysis provider. So our first question is whether she is entitled to continuity of care to continue her care at RISA. So this is somebody who's moving from fee-for-service to a managed care plan. We actually don't know, but let's assume that she is required to enroll in managed care plans. So this is a mandatory move. And this is the question is whether she is entitled to continuity of care in this situation. So I think some considerations, and I know we did not go through the providers who are entitled to continuity of care. But one thing you will see on this list, so this is kind of a trick question, is that dialysis centers are not one of the provider types for whom people are entitled to continuity of care when they're moving from fee-for-service to managed care. So in Selena's situation, she is not entitled to continuity of care. Ooh, sorry, my cat wanted to be a part of this conversation because her provider is not one of the eligible provider types. However, you'll see the next part of the question is if she has some appointments scheduled in January, the 5th, the 12th, and the 19th, will she be able to keep those appointments? And the answer is probably yes, because these would fall into the exception for either for already course of ongoing treatment, as well as the Knox-Keene protection for people who are receiving treatment for a chronic condition, an ongoing chronic condition. Again, we don't know exactly why she's receiving dialysis, but I think it's probably fair to say that she's receiving dialysis in an ongoing way because of some long-term chronic condition. So most likely she would be able to keep those appointments and then would have to work with her plan to identify a new dialysis provider that is in network with her plan. Our next example is Blake. We can go to Gigi, who is a 13-year-old placed in foster care in San Bernardino in 2023 and enrolled in IEHP for several months. Sorry, there's a capitalization error there. She's been seeing an enhanced care manager to help coordinate her services and care. In February 2025, she was placed in Los Angeles County and enrolled in LA Care as of April 1st, 2025. So the first question is whether she can continue to receive enhanced care management with LA Care, and then will she be able to continue seeing her enhanced care manager now that she's enrolled in LA Care? So I think for the first question, this is sort of the situation Kim described where her placement changed, and as a result, she was enrolled in a different managed care plan. Because it's a move from one county to another, this is not a situation that entitles Gigi to continuity of care. That said, if she's eligible for enhanced care management, she should still be eligible with LA Care, and so hopefully she would be able to work with her plan to continue receiving that service. But most likely she will not be able to continue seeing her previous enhanced care manager from IEHP, since that's somebody from a different county. She'll need to see an enhanced care manager who is part of her new managed care plan. I think we're close to time, so I can stop there and see if there are any final questions or turn it back to Peter or others to do any wrap up.
Perfect. Thank you so much for the wonderful presentation, Kim and Abby. So just to quickly tie things up, thanks for joining us today. If you have any questions, please feel free to reach out to us. I believe that Kim and Abby put their contact information at the end of the presentation. Please note that the presentation and the recording will be posted on our CVSI webpage. I put the link in the chat again. So please look out for that. And again, if you have any questions, please feel free to reach out to us as well. Please take a moment to provide your feedback by filling out our 3-minute survey. The survey link is in the chat. Thanks again and have a great day.
I think Baljit's gonna say something real quick. Yeah.
Okay.
Yeah, if folks can just hold on before you leave. So really want to appreciate and thank Abby and Kim for this wonderful presentation on continuity of care. We're hearing from counties across the state about what is this? What does it mean? And hopefully we've provided some more context to it. Would like to say that we also have partners with us here from CDSS and DHCS as well. And so really appreciate our state partners being on this webinar with us. And I want to give a moment to Kim and Abby to kind of share with us real quickly, because I know time is running out here, kind of the larger space that you're in regards to this work with Medicaid and, vulnerable populations, especially the foster youth population. So I just want to give you a moment to really share what you're doing in this space as well.
Sure, I can start, and thank you. We obviously are a national nonprofit. We've been working in California on policy and litigation for many, many years. My background is with having been involved with the KDA lawsuit was to bring services to foster youth in California under Medi-Cal in terms of like the intensive care coordination, intensive home-based services, therapeutic foster care that I was involved with from 2002 through for about 2 decades to ensure that kids in California have access to these services that they're entitled to. So that's kind of background for me. So we do a lot of work in the intersections of these populations with Medicaid. Our area of expertise is Medicaid and also the Affordable Care Act. We're obviously fighting for against cuts on the national front right now, as much as we are also working on very detailed policy implementation in California on an ongoing basis. So, not just ensuring that they're following the federal law and also that the policies are consistent with federal law, but also arguing for expansive policies and practices that are going to protect access for all populations, including foster youth, specifically in California. So we do work with a lot of direct service organizations and child welfare advocates, as well as Medi-Cal advocates on all kinds of policy issues and help them with technical assistance on cases they see coming in the door, including our Health Consumer Alliance, which is a statewide health consumer advocacy hotline that people can call for help with any Medi-Cal healthcare issue.
Great. Really appreciate that. And like Peter said, we always encourage the survey. It helps us to kind of formulate what other brown bag topics and webinars or additional training that you want. And if anything comes out of this that you're questioning about how do I resolve this with the child in continuity of care, again, reach out to myself. Reach out to anyone on the CFPIC team, and maybe we'll reach out to Kim and her team about help us navigate this a little bit more to better understand it. So again, really appreciate it. And Andrea, Laura, Peter, if there's any last words you guys want to share before we close out.
No, I just echo the thanks. Thank you so much, Kim and Abby. And we know that you guys have a lot of work cut out for you, and we are really grateful that you are blazing the trail and getting the guidance that we all need. So thank you so much in advance for all the hard work that you're doing. And we appreciate your time today.
Appreciate it.
Thank you.
Thank you.
All right. Enjoy your lunch if you haven't already had it. Enjoy the rest of your Wednesday. Thank you, everyone.
Thank you.
Bye.